surprisingly, I'd say 80% of the audience was students that were at this, and their club actually did kind of a version of Ending the Silence. They made up their own version of it where they shared their stories for the first time. They each talked about the different diagnoses, the early warning signs and symptoms, and those kids were not on their phones, they weren't fooling around, they were all paying a lot of attention. Did you get a lot of new members?
Yeah.
How many?
I mean,
Hard to know yet.
yeah.
But I mean, it was really amazing. I mean, it gave me goosebumps to see, you know, the interest and how many students came to that. So they're doing really good work at their school. What was the other thing you did with the sticky notes?
Oh, that was
Yeah.
I like that.
Yeah.
So we did a positive post-it day. So we spent a few weeks making hundreds of post-it notes, writing positive messages and cartoons and stuff to make people smile. And we put them all over the lockers. And so there were like 300 or 400 lockers, and we covered all of them, and we put some around campus. Yeah.
We're doing really good. And we're doing our first NAMI on campus for high school, so we're looking forward to that. So thanks. Isn't Andres a good speaker at the last minute? Thank you for singing. Okay, thank you so
I'm
much.
going to start charging. This is ridiculous.
Okay, thank you. Okay, so I think we can ask Toni to come up now. I don't have, unless anybody else has anything burning that they want to talk about. We're very lucky tonight to have our not so new now anymore Behavioral Health Director, Toni Tullys.
Okay, so I'll just
So she started in December of 14, I believe, right?
yes, well, sort of.
Sort of.
I really
You got
started.
the tour.
I got the tour. January of 15 is when I really started. So,
So I'll turn the microphone over.
and I have to be honest. I had we have one son. He graduated from college in New York 3 weeks ago, and I got off the plane from New York, and I've had sciatica for the last 3 weeks. So I cannot stand in front of you, or you'll see me like screaming. So I'm going to sit. We'll pretend like it's Oprah Winfrey or something.
here's a bottle of water. Oh, thank you. I have my notes, but I think I'll remember everything I want to say. First of all, thank you all for inviting me, and thank you for the important work you do. Kathy and I had dinner together tonight before the meeting, and I said to her, and I want to say to all of you, that just the tremendous effort of this NAMI and the dedication and the work you do in the community and the work you do with family members and the work you do with consumers, it's so impressive. And I know that that's part of the NAMI mission, but I'm just extraordinarily impressed with what Santa Clara County NAMI does, and I'm really honored to be the director and to be here with all of you tonight. So really, my hat's off to all of you. What Kathy wanted me to do is walk through where we are right now in behavioral health. When I met with you just over a year ago, I really was a novice. I was just I couldn't even find Good Sam Hospital. And now I feel like I don't live here, but I really live here. I spend most of my hours here in Santa Clara County. And there's been a lot of change over the course of the last year. So I'm going to focus on our services because I think as NAMI members, what you're probably most interested in is hearing about the services that we're expanding in the community because there's quite a bit going on. And then I'm going to open it up to all of you and ask you to ask me questions, and I'll answer questions as best as I can. The first thing I want to say, young man in the back who did the voice with the young girl. Did the young girl leave? Katie leave? Oh, there they are. Okay. So I have an idea. If you want to work with high schools, our behavioral health children's system has contracts and staff in almost every high school in Santa Clara County. So I would be really happy to work with Kathy and with you. Katie, I would like you to come and speak to our managers team, both of you, because I think it'd be really important for them to hear a young person talking about what you're doing at the high school level. But I think we could get you really easy access to the high schools. And if I'm wrong, we'll figure it out. But we do have school coordinators in I think about 30 of the schools in the county, 30 of the high schools. So let's make that connection for sure. And I'll introduce you to our children's team, and then off you go. Okay? But I'd very much like you two to come to one of of our managers' meetings, probably later in the summer, to talk about what you're doing in school, because it's inspirational. And like your dad, I like to make fun of my kid too. You're proud of him, you embarrass him. But I think it's really important to hear both about prevention and about recovery. And the reality for our work is there's not a decision that I've made since I've been director, there's not a decision our team has made that is not about the people we serve. It is always about the clients, no matter what their age, and the family members. And family members can be biological family, they can be just dear, dear friends who serve as family, but that is the core and the real focus of our work, and it's why I'm here, and it's why my staff is here, and why all the providers are here. So what I wanted to walk through is some of the many changes we've made in the last year. One big one, and we have had, Kathy's been involved, and we've certainly done focus groups with family members. One of the first things I learned when I arrived on the scene is that our 5150 policy could use a little bit of work. And then the more I did, the more I realized there was more work to do. So since last October, we've had a very significant work group with representatives, every stakeholder imaginable involved in mental health. Hospitals, emergency psychiatric representatives, consumers, families, providers, our staff, community staff, you name it. They've got law enforcement, emergency medical services. Everybody that's involved has been part of this very large conversation. We're nearly finished now. I've got one of the staff people is developing the draft. But what we've done in this work is look at everything related to what we think of, the shorthand is the LPS, Letter and Petra Short Act, but all of the involuntary services. And what the expectations are, if somebody needs a 5150, how we can improve the protocol and the process so that we really keep it human-centric. And we've learned a lot. We've had focus groups, we've had a lot of feedback. And now what we're developing, we're looking at the legislation, but we're also looking at how can we make the process more humane for the people that are going through the process, and what does our system need related to community-based crisis services. So the first thing that became very evident is we had no mobile crisis team for adults. And we've developed and released an RFP. We're actually in the process, I think next week, the proposals will all be in, but we'll be selecting contract providers to manage our mobile crisis teams, and those teams should be up and running October the 1st. So that's a big change for Santa Clara County needed. The other thing that was underway with Dr. Nancy Pinion, my predecessor, had just started, and we're nearly finished, is October 1 as well, we're expecting to open 2 crisis residential facilities. A crisis res is voluntary services. It is not going to the hospital. It's hopefully getting people long before they're in crisis to the degree that they need to be hospitalized. Crisis residential is usually 2 to 3 weeks. It's 24/7. It's got intensive services. And the staff that work in these facilities are really helping somebody figure out what their next plan of action is. So the plan could be that they go into one of our services. The plan could be that they've got really good supports in the community, they were having a tough time, they need a lot of peer support, they may need to develop a RAP plan. It just depends on the individual person. So we will have a new crisis residential facility with 15 beds in East San Jose. In addition, because of the high number of crisis calls we have in San Jose, we'll also be standing up what we call a crisis stabilization unit. And this is like a mini EPS, but it's not an EPS. So people can be there 23 hours, 59 minutes. The services will be available 24 hours a day. And this is another vehicle to try to keep people out of EPS. If somebody needs acute psychiatric services, they need to be hospitalized, we want them to have ready access to EPS. But out of the 6,000 or 7,000 EPS visits every year that we have, only about 20% of the people that are coming through PsychER are actually in need of hospital service.
bulk of people who are showing up at EPS are in crisis. And there aren't other places for people to go in Santa Clara County. So everybody sort of funnels to EPS. And then unfortunately, they're released from EPS most of the time not with a connection and may not live in the San Jose community. And so there you have it. It's not the greatest system. So we're developing in East San Jose, which is the highest number of 5150s, the highest number of crisis calls in the whole county. The crisis residential adjacent to a crisis stabilization unit. We'll also have a mobile crisis team that will be serving this whole mid-county area. And so if somebody's in crisis, you can call a mobile crisis team. They can come and do an assessment and figure out if we can get somebody over to crisis res, if we can take care of somebody through the night and then get them connected to services, or if indeed they need to go to psych ER. So that's a big change in the county. And all of that will be standing up in October. On the children's side, we're doing a couple of things. I think many of you may be familiar. Supervisor Simidian, about a year ago, came to me and wanted to talk about a children's hospital. All of our kids in Santa Clara County up to age 17 who need acute psychiatric services are sent out of the county for that care. So if you're a family member, and let's say you're a family member that works, and your child is residing in a hospital that's way up north, it can't, and especially if you're low income, it's not the easiest thing to try to be with your kids. So we strongly support this idea. We also had a planning committee. Kathy's always involved in these things with us, but we had a large planning committee to really determine what was needed in this new children's hospital. And we developed a request for information to see who might be interested. And then from the county, we released a request for procurement, meaning we want somebody to submit a proposal. We say, yeah, who? We want you to be the providers of the service. So we expect the proposals to come in the last week of June, and they'll be evaluated through July, probably into early August. And then hopefully we'll be able to make a decision and move this forward. As it stands right now, we don't have currently any facility based on the information we had in our information request that's ready to go at this moment. So we may have to do something that's kind of a stopgap measure. But in the end, the goal is to be able to have kids with psychiatric needs treated here where they live. And we're all dedicated to that. In addition to children's, which was approved today, is very exciting, EMQ put together, we have a contract with them on the children's side for children's crisis services. So they have a long-time mobile crisis team, and then they also have a crisis stabilization unit. And the goal of this unit is really to keep kids at an emergency site. We don't want kids there. We really don't want kids there if we can avoid it at all. And we also look at designing all of this. We're looking at a lot of data, like when do people use 5150s the most? Where are the people in the county being brought in into EPS? What time of day? What's their age? What's their gender? Where do they live? We're looking at all that data. And on the kids, we're looking to see where the peaks are. And what we've learned is kids are coming into crisis, imagine school-age kids. It's always just before the holidays. It's always in spring with finals and tests. And then there's a lull in the summer. But you see big peaks during the school year. So we have 7 beds at EMQ, and what we're seeing is when the demand is high, kids are having to be offloaded over to EPS. So we went to the Board of Supervisors and I requested funding from the county, from the CEO of the county, and the board supported it today, to extend from 7 to 12 beds, which would really allow kids almost all the time, we're hoping, to go to EMQ and not to wind up at EPS. The rare thing may happen. EMQ, in addition, does a 90-day transition plan for all the kids that go through that program, and 87% of the kids have not returned to crisis services. So we're going to use that same process when we stand a children's hospital here, a psych hospital here in the county. We're gonna expand that, so any of our kids that are in the hospital will also get that service, because we believe it will support families, it will support kids, and it will reduce recidivism into the hospital. So we're building out both adults and we're building out children's. Conversations are underway right now. We're looking at the development of urgent care centers. We're looking at a model in LA County that we could scatter. The county is very large, and for people that live in South County, coming up to EPS is a 40-mile drive. So we really want to have more crisis services in the southern part of the county. But we're also looking at mental health urgent care centers as a means for an individual or a family to have a place to take somebody that is not the psych ER, where there'll be staff we'll have psychiatrists, we'll have clinicians, we want to have peer workers, but there would be a safe place to go that's a voluntary place to go, and hopefully that would also reduce those last minute really awful runs to EPS. And I'm not being critical, I want everybody to understand, I'm not being critical of the work that EPS does, but they're the designated psych ER for the entire county, so that's where everybody comes. And the more capacity we can build in the community, the more options people have when they're facing crisis. And right now, that's our biggest priority in behavioral health. So we're moving things along pretty quickly. We also are building yet another facility that's in South San Jose, and I can't remember, Kathy, used to be the Girls Juvenile Ranch. It's a beautiful hilltop park, beautiful, South County, green, very recovery oriented. I want to say it's that, it might be that. It's called Muriel Wright. Does anybody know that? Okay. There's a beautiful place on top of the hill. And the county has learned a lot about our needs in this past year. And so the county has given us the space, and we're going to create, by October of 2017, we're going to create a drug treatment residential respite service for both men and women, and an additional crisis residential facility for 15 people. So I want you to hear that we're going from about 35 crisis residential beds to we'll almost be to 100 in a year. So that will make a big difference. That should make a huge difference. So that's kind of from a crisis standpoint. And I say crisis because it could be urgent. And if you're family members, I would imagine if I asked you, everybody in this room would raise a hand about having had a crisis experience. And if I asked you, was that a positive experience, I would bet that 50% or more of you would put your hand down, because it's not always been a positive experience anywhere. It's not about Santa Clara County. So what we're putting in place, we hope, will be a much more humane way, personal way, to be able to deal with people in crisis and keep it at a much lower level so that people can get what they need without having to go to acute psych. And if they need acute psych, we'll put them in acute psych, but we want to start at a different level. So any questions on that at all?
The 5150, how does that relate to?
Well, 5150s are involuntary holds. Involuntary. They're part of, we are, on the mental health part of our organization, we have substance use housing and mental health. We are a Medi-Cal managed care plan. It's a unique situation in California, and we have a particular act that was approved many years ago now, called the Lanterman-Petrus Short Act, to really give, to protect rights of people with mental illness. And so a 5150 is the short, is the abbreviation. It's actually the code within the legislation in which a clinician or a law enforcement officer can assess somebody's needs, can determine if they are a danger to themselves, a danger to others, or gravely disabled. And if they meet that criteria, and the criteria is very broad, if they meet that criteria, they can be put on a 72-hour
involuntary hold. And during that involuntary hold, they are, in essence, they lose their civil rights. I'm just gonna, it's what we talk about in our 5150 meeting. And so in addition to having the authority to write those holds and for the director, the role I'm in, to designate who can write those holds, we also have, and we're required to have, a very robust patient rights effort in this county, and the mental health advocacy project through, what's the law group, works with all of our clients. Mental health advocate, MHAP is what I call it, but all of the lawyers work on behalf of the clients we serve. Any other, yes sir, in the back.
Who's going to be the staff of the mobile crisis team?
Well, we don't know yet.
I don't mean that who gets the contract, I mean, what are the qualifications?
Oh, we have a lot of qualifications, so we will need to have a licensed person on the team at all times, but we're also looking at unlicensed staff. We're supporting peer family members who could be part of the team. But we will have teams there. We don't have physicians on the team, but we will have a licensed clinician. And we are expecting that anyone that we select for mobile crisis, all the staff will go through crisis intervention training, de-escalation training, all of those trainings. We want them to be at the forefront in terms of using those trainings and techniques to help people in crisis. So I'm a strong, strong believer in consumers and families being involved in crisis where possible. I know that the San Diego model, and I want to call it IHOT, in-home, what is it? It's the family outreach model. Is it IHOT? I think it's like that in San Diego. There's a model that San Diego put in place. They're now implementing. We decided to do it when I was in Alameda. A program that is not a mobile crisis team per se with clinical staff, but it's really sort of a case manager, a family member, a consumer, and they actually go to people's homes when a crisis is brewing. They're not service providers. They create linkages and determine what people need. It's been extraordinarily successful. And that's one of the programs that I'd like to bring to this county. But that's all basically peer and family run. Yes?
So, I have 2 points, and I'm not necessarily looking for you to be able to answer today. It's more just pointing it out.
Okay.
So, I had a scenario this year where my loved one was went to a place out of county
Yes.
and could not come back into the county because instead, was it 5152 is after 5150?
It's a 5250.
5250, I
Yeah.
never can get the number.
Yeah.
But at that point, he could not come back in because the number system and the legal system don't use the same criteria. So if they wanted him to cross county line, he basically would have not been on that hold anymore. So that was just, and this is at a place in Concord.
Is your son a resident of Santa Clara County?
Yes.
Hmm.
Which also created other problems, because right now he's doing insurance, so he was up there on private insurance, and again, couldn't come back any closer. And as you were talking about, it was so hard being a supportive parent. I could barely go up there 2 times, it was 50-some odd miles
Yeah, it's a long
each
drive.
direction. It was awful. I mean, they did, I'm not saying they didn't do a job, but just the experience as being a loved one was really hard. And then
Well, I think the point, first of all, I want to say, as a mom, that's just a hard situation to be in, and it doesn't sound like it was very easy for you at all. So when I talked earlier about the 5150 protocol, one of the things, and I've certainly seen this in this county over the last few months, we have trained a lot of CIT officers. And the last training, there was a huge amount. We've got NAMI there now. We have now trained officers in every local jurisdiction. And now we're training the sheriff's department, all the deputies in the sheriff's department. But there's still a lot of opportunity for learning. And I think in your situation, you're raising a particular issue that's doesn't happen all the time, and I can try to get some answers for you. It's different, to be honest. The reality is if you are on commercial insurance, it's a little different than if you're on Medi-Cal. There are differences there in terms of moving from one area and one hospital to another hospital. But when you're talking about trying to explain the situation, I think there are a few things that we can really look at. And the form, I want to say, yeah, 1424, because it was 1421 as AOT. The 1424 family form, I think, is really, really important to have. And I strongly support it, and I don't know if you've done a training on that recently, but for this family form is something that a parent or a loved one can complete, and you can actually share it with law enforcement. You can share it with a psych doc. It provides opportunities for families to give input. And I think one of the most difficult things for family members is, as many of you probably know, if you're 18 and over, because of the HIPAA laws and the mental health advocacy laws, anybody 18 and over has to give permission for you to know about what's going on, to talk to the doctor, to hear all those things. And that doesn't always happen, and it often doesn't happen in the midst of a crisis. So learning about the 1424 form and having that available would help in those situations. And I'll tell you what else would help in those situations. If your child, or if anybody's child, is on the verge of what you know is going to be a full-blown crisis, you bring them to Crisis Reds, you call our mobile crisis team, and let us intervene and help you. They're not up and running yet, but that's exactly what the intent of those teams is to do. Yes?
Will the mobile crisis unit be 24 hours?
We started it as 12 hours because we've looked at the data, and the truth is after midnight, the 5150 calls really plummet. The highest hours are like 9 to 12. So we were going to start them 12 hours. We're going to re-look at that, but we want to get the RFP proposals in, and we'll see. We've actually talked to mobile crisis teams across California in big urban areas, and I understand that we started some teams in this county as well many years ago, where the staff just sit around most of the night. So we're trying to find the balance. The intent would be they'd be 7 hours a day, 7 days a week. And we would launch them starting at 10 or 11 in the morning for 12 hours beyond that, because we've looked at data in every local community in the county. So we have a really good sense of what's happening where and what time of day these things occur. And what we've said is if we see demand for the services beyond midnight, then we'll expand it beyond midnight. Other questions? Oh, yes, sir.
As you're well aware, we got a problem in the jails in this county.
Do you want me to talk all about that? No, go ahead. I'm really involved in that, yes.
I know you are. But my question is a little bit more specific
Okay.
than just there's a problem. It is of these nice changes that you're introducing, and I really say they're good changes. Do you see any of these helping reduce the number of people with mental illness that end up in jail? Because at least I think in many people's opinion, probably yours too,
Yes.
a lot of the problem in the jails is we got too many ill people in
Yes.
there who shouldn't be there.
Yes.
So will these changes help reduce that problem?
If they don't, fire me.
I'll remember that.
No, quite honestly, it's For those you've heard me speak, and I was saying to Steve earlier when we were walking in, I started nursing when I was 16 years old. And I'm proud of my age, and I share it because I want to model for all the women. And a career changer, I'm trying to model. I'm 62, I've been in healthcare 40 plus years.
You don't look it.
And, well, I look pretty darn good for 62 with sciatica. Yes, thank you. But I'm pretty darn tired. This job keeps you going. But I want to say that for me, and that's why I'm here, for me, the group that has been the most isolated, the most stigmatized, in every conceivable way in my 40 years, and it's why I'm in mental health now, are people living with a mental illness. So in any jail, anywhere in this country, and we've done research nationally, what you see, it's a long litany of poor social policy, funding, you name it. But fundamentally in Santa Clara County, I want to say this. The county leadership, that Dr. Jeff Smith, our CEO, Renee Santiago, the health executive who I report to, I've worked for both of them, the commitment to addressing the needs of people in this county is so significant. The board is so supportive. It's why I come down 50 miles a day. I live in Oakland to work here because I'm so committed and believe so strongly in the leadership and what we can do here. But fundamentally, people with a mental illness need treatment. And in Santa Clara, for a lot of reasons, like many other counties and many other communities across the country, people wind up in two places. They wind up at EPS and get spit right back out. Or they do, as I call it, really dumb things. And I mean, they're goofy, they may act, their behavior may be unusual. You know, people can go steal some candy because they're hungry and they like that candy. It doesn't matter. It's low-level misdemeanors, and it's because they have untreated mental illness. So when I came to the county, the situation at the jail had not yet occurred. There had not been the murder. There had not been all of that. But fundamentally, I was looking at data on EPS and saying, my gosh, the data is telling me we've got huge demand, not enough services, and most of the people aren't being put in the hospital, so where are they going? Well, you know where they're going. If they're not coming to EPS, they're getting picked up and going to jail. So the health and hospital system, I have to say behavioral health is at the forefront working in custody, but Dr. Tiffany Ho, our medical director, is bringing in teams. We now have psychiatric services for people who have acute mental illness inside the jail. We are working very, very closely with custody staff, with correctional staff, with the sheriff's department. We've had lots of expert input. But on the custody side, really looking at what must we do for people who are in custody and have a mental illness, and make sure that they get the treatment that they need. So that's underway. The other thing that we're looking at, and Kathy's involved in this, there are many of us now on a jail diversion committee, which the county is very committed to doing. And now what we're doing is we're looking at best practices across the country for people with mental illness who are winding up in jail. It's a national problem. It is totally a national problem. So the gold standard in the United States is in Bexar County in Texas, near I think San Antonio. And another really good example is LA County. And LA County is the largest public mental health system in the United States. So one of the recommendations we're making, and Supervisor Chavez and Judge Manley and all the people on the commission support this, is we want to bring a Santa Clara team to look at these. They're called restoration centers, where you have a lot of services in one place, and the law enforcement, instead of bringing people to jail, bring them to this place where they get services first. And what we're looking at are assessment tools, we call them assessment tools, that law enforcement could use in the field. So if you've got somebody whose behavior is unusual, or who clearly looks like they need help, and what they're being arrested for is a really low-level, nonviolent misdemeanor, where we want to go is somebody that is doing low-level stuff and has really significant mental health or substance use symptoms. we want to create a tool with all of our law enforcement and public safety partners. There's high support for this, where those people can go to one of our centers and get the care they need. And all of the programs that I'm describing are for people in this county who are in crisis. So my hope would be, as we continue to develop and link these services, that we will see three things. We should see a reduction in the number of 5150s at EPS. We should see a reduction in the number of people who are booked into the county jail. And we should be able to track people and see that these individuals are engaged in services, are not being hospitalized, are not being put in jail, and that their mental health and their overall well-being is improved. So that's the ultimate goal. And I'll be here for years until it's in place, because I'm not walking until that's all in place, and we have those numbers. Yes? So sorry.
How did the jail or even whoever cannot see this case being assessed? So there should be some criteria. If this repeated, same thing repeating every month or every couple of weeks, there should be a mandatory assessment at the hospital or the jail.
If someone is going to EPS, it's by law, they have to be assessed. I would say that in the past practice in the county jail, that would not be the case. That's changing pretty rapidly with all of the improvements that we're making in the jail. And certainly with Dr. Ho and all the psychiatrists that we have there. But I think you're raising another issue, and I want to use lay terms, not our clinical terms. If we have somebody in our system that shows up on our system as being what we call a frequent utilizer. So if we see that somebody is going to psych ER, repeatedly going to psych ER, and yet they may not be hospitalized and they may not be in our services. So we know that there's somebody in the community, they're going to EPS a lot, that tells us there's a problem. What we're working towards now, and we don't have it all in place because we're putting all these other things in place, is we really want to start looking proactively at people like your son who are showing up over and over again, and then developing services to engage him. We call the word engagement, to really connect with him. And often with young people in particular, it's very true of young people in general, but young people that have a mental illness or a substance use issue or a combination of both can be very, very difficult to get engaged in services. They don't want to take meds. They don't want to have a mental illness. And I'll just be honest, I have a niece who's bipolar, and my sister, and anyway, it's the same thing. She was hospitalized, she turned 18. There was no information shared. It's been the whole story, okay? But fundamentally, they don't want to be ill, they don't want to take meds, they don't want to be different in that way. And so one of the things that I want to see more of, particularly for young people, is I want, like this young guy up here, I want to see a lot more young people who've gone through that and have that lived experience. And the most powerful work I've seen in the 12 years I've been in mental health have been with youth between the ages of 18 and 25, talking to somebody else in their age group who's gone through it and can really connect with them. They can connect more effectively than clinicians or physicians often, because a young person can, they're young, they do their whole young person thing. And I want more young people working in our system. So when somebody like your son is in and out and in and out, we have to be careful with privacy rules, but we're looking at ways that we could connect somebody like your son to a transition age youth group and say, here's a place you could go and hang out and keep it very loose. But in my experience, my staff experience, is that that is something that young people will connect with. They don't want to be at the hospital. They really don't. They're very tough to engage. And they're very difficult to engage in services once they're released from a hospital. If they're over 18 and they're voluntary, it can be really tough. It's a very tough group to work with.
So that comes to the next question. Before it was diagnosis, it was about critical time to assess them
Right.
early enough. I think that is lacking tremendously. Another one is after they were diagnosed, it's 50 to 150. Doesn't really work because 3 days old. You know these psychosis, they come and go, and they can present themselves really well
Yes,
in
they
front of the
can.
judge. And it's during the denial stage.
Yes.
Right. So that's also very lacking because 5150 was so broken. Like he can't get off easily. Every single time he gets off, and
So
never been stabilized even after diagnosis for a long time. Because it's 3 days, you can't really stabilize a patient in 3 days or 14 days in many cases.
can I ask you a question? Well, let's talk afterwards. I don't want to ask you private
So there's very
questions.
critical two
Yeah.
points that's missing. One is early assessment.
Mhm.
One is 5150. If anyone wants to have kids that has mental illness, 3 days, 14 days, there's no way you can stabilize the patient.
Right.
You can't even find the right medicine for that period. So you just release them until they get worse and worse. They get to the point that they get to the worst point. The whole system right now is waiting for the kids to the worst case possible. And then they figure, okay, I'm real. That's about a long time. We're talking about a couple of years, the kids could be stopped
Mhm.
before they get to the point they even totally disabled and become a permanent disability, a disabled kid in the society. If you look at the cost is much more if you kick the ball down the road. That's what I'm saying. We've got to work on early assessment and get them stabilized early enough before they get worse and worse.
And I understand your point and I support it. And I think the other service I should share with all of you, it's not going to solve all the problems, but it's pretty cool what we're doing. We are developing, it's called Pay for Success. It's a new way of contracting to try to improve health outcomes. And we're looking at people over the age of 18 who are frequent utilizers of EPS, may be hospitalized at Barbara Aaron's or somewhere else, but we're really looking at what can we do, looking at very well-described criteria. How can we pick these people up right out of EPS, give them very intensive services over a long period of time with the goal that they're not returning to the hospital and that with any good luck, they're not returning to crisis res. It's a 6-year pilot. It's worthy of a lengthy discussion, not a short, abbreviated discussion. But I'll tell you that this is the only, Pay for Success is something that is a social, new social model, a new way of contracting in the public sector. It's all about improving social outcomes. So we're also doing one to reduce homelessness, but we're the only jurisdiction in the United States trying to address these needs in mental health. So it's another piece of the pie, trying to capture exactly what you're describing. I do want to say to all of you, the most common thing I've heard in my time in this role in an Alameda is exactly what this parent has described in terms of the 5150 process. Your loved one is in, they get spit out, maybe they're in for 14 days, maybe they're not. You know them better than anybody. Why are they getting released? And the reality is the clinical judgment of the criteria on grave disability, danger to self or danger to others, And what we know, what you all know, what I know about my niece, is if she gets a shot of medication in the ER, she clears up pretty quickly, and she is doing real well, and out she goes. So the reality is the clinicians are not being unkind or insensitive, but you cannot keep somebody on a hold if they don't continue to meet the criteria. That's the law. That's not the hospital, that's not the provider. Now, some providers are a little more generous than others might be, but the reality is it's a legal decision, and so that's what happens. And we know if people get medication that they can quickly clear up, and so they no longer meet that criteria. And it does create an in and out cycle, and everything I'm describing today is to try to prevent that in and out cycle and to have much, much, much lower level voluntary services in the community that can address somebody's needs, probably engage them in a much more meaningful way, and divert them from the 5150 staff. I do want to hear there are a lot of other hands, so I appreciate what you said, but I've got many other hands here. You way in the back?
Yes, hi, thank you for being here, first of all. And I was just wondering what's happening with patients with eating disorders, and who is the county referring them to? And also, is the county staff getting trained on how to handle eating disorder cases?
Yeah, we're doing more and more on eating disorders. There are very, very few eating disorder organizations, facilities in California. So we've contracted with the facilities that provide residential services. We're working with eating disorder specialists, clinical specialists. We don't have frequent requests for those services. We've had a handful of people who've needed them in my tenure here, but
How do you find who you're contracting with, who the county is contracting with?
well, there's only one or two places in California that offer the services. So it's, I think all the counties are using pretty much the same folks. So we contract for those services, and we have the eating disorder clinic over at Stanford, and so they make recommendations. We've looked at the inpatient services that are offered up in Berkeley at Herrick Hospital. The reality here, and it's kind of a sad state of affairs because this was a policy shift at the state level, Kaiser had the most robust eating disorder program anywhere. They had every level of care, and it was fabulous. But then at the policy level, they said this should belong to specialty mental health. So all of the counties are trying to figure out how to address these needs. And I would say since I've been here almost 18 months, we've maybe had 8 clients and eight admissions. And of those 8 admissions, we probably were serving 3 of the same people. So it's not a high number. One of the things we'd like to do, it's what we did in Alameda. I come from Alameda, we did a lot of work on this, is we really tried to pull in, and my children's team is doing it now, we're looking at training for clinicians. So if clinicians would like to become certified as having expertise in eating disorders, we have more of an array. It's a very particular type of therapeutic alliance, and it's not your traditional working with somebody with mental health. For those of you who aren't that familiar with eating disorders can kill you. I've seen people in this county, in Alameda and San Francisco, young adults who weigh about 50, 60 pounds. So this is a mental health issue, but it is very serious physical health issue. And in all the things I've seen in nursing, between the early AIDS deaths and eating disorders, those are the 2 worst things I've ever seen. So we know that when somebody's really ill, they need a lot of intensive services and long-term services, which we cover. We pay for it. It's very expensive. It's also because it's so limited, they charge a lot of money for these poor people. Yes?
Question, and I really appreciate you coming and what you guys are doing. And I understand the need to focus on crisis right now because we don't have a system that works.
No, we don't.
So I think this is great. I wondered if you also, though, had information about any I know it's expensive in this valley, I get
No,
the
it's bigger
housing,
than that. It's
I-
much
you
bigger
know,
than that.
But are there any plans to move something further south that would be available?
Well,
Or,
I'm not, Key Lee is our housing expert who I work with. So I'm not gonna go delve into the housing thing too much because Key is the expert, but I will tell you what I know about Santa Clara County. Santa Clara County is an extraordinarily fabulous county. It is currently the most expensive county to live in the United States of America. So my fantasy when I accepted this job, truly it was my fantasy, because I live in Oakland, it's very urban, there's no space. So when I applied, I was driving around, I was seeing all this vacant space, and I thought, oh, we can build all these things, it's gonna be so wonderful. Well, the county is aggressively purchasing properties. I don't think that anybody realizes how aggressive Santa Clara County is to try to address the homeless issue. In this county, and in many, many counties, all the urban counties in the Bay Area, what has occurred is a decrease in the number of residential care facilities, very substantial. And why this has occurred, there are many reasons, but let's just say 10 or 15 years ago, I want to be as diplomatic as I can. People were on Social Security, their Social Security payment could cover the expense of their housing. Housing costs were much lower. People did the work because they cared about the individuals who usually had behavioral health needs or other kinds of needs. And they also made, I'm not complaining, but they made some money off the business. Well, now the cost of housing is very high, and we have, there is a push to try to get people licensed. And if you become licensed, there are many more regulations that you must meet. And to meet all the regulations, you have to pay more money for staff, and you need licensed staff. So the costs have gone up just in the living situation. The costs have gone up for those who are licensed. The reimbursement for people living on Social Security has not gone up very much. Are you all with me? Are you seeing what's going on?
Yeah.
So when I arrived here the first week, one of the first things I learned about is that we didn't have enough residential care facilities, and we don't. We have done everything. We released an RFP, we chatted it up, we went to behavioral health providers who are not in the residential world and tried to encourage them to apply. We've really been over backwards. And it has shrunk so much in the county that there are very few beds. So the county is aware of this and is doing all they can to purchase properties and to own the property so that we can bring a service provider in, but we're also not at the mercy of property owners. We really want to own the facilities. But it's a challenge for us. It's a challenge for the county. But I want you to know that I am so impressed with what Santa Clara is doing to reduce homelessness. I mean, they put millions of dollars. They're very aggressive. Key and his team are looking at, with support from the county exec's office, are looking at every conceivable way to align funding to maximize vouchers from the federal government. We've got a very ambitious housing plan here, but in the short term, it's very difficult. It's very, very difficult. And we don't want to send people out of county. I've made some tough decisions recently, and I don't want to send people whose loved ones live here out of county because somebody else has a facility. And I also feel very strongly, as does my team, I want our staff to be able to go to the facilities because we want to make sure that people, because many of the people are somewhat impaired, we want to make sure that we monitor and that people are getting the care that they need. We feel very strongly about that. So I have a team that does that.
Thank you so much.
Oh, you're welcome. Go ahead. Beautiful red hair.
It's turning gray because I'm letting it go gray.
Go Gray. Go Gray.
My name is Clara, and I sent out an email to you. You might have remembered me, but I don't know if you did. But I'm on conservatorship, and I am waiting to get into housing, but I have been trying to get into housing in Santa Clara County, and been at risk for homelessness for 18 years, and I'm trying to get into housing.
bouncing around the mental health system for 18 years, from one program to another, from boarding care to boarding care, from one program to another. Crisis residential used to be 90 days, now it's just a couple weeks. I've been, from hospitalization to this, to that, to the streets, to this, and, when am I going to have an opportunity for permanent housing? And MHSA housing excludes me.
Have you talked recently, I'll get you a phone number for somebody at the housing team. They do have criteria. It's criteria across the county, but I think it's really important that you actually talk to the housing people. They're not the service team, they're the housing people, and find out, and I'll make sure you get a connection.
I've been, on conservatorship for the last 18 years. I've been at risk for homelessness for the last 18 years. And, I feel like, the criteria for MHSA housing is, homelessness or at risk for homelessness. And I'm at risk for homelessness, and I have been homeless at times. And bouncing around the mental health system, many times at homeless, being at EDP or being at Crossroads or being at this program or that program. I'm homeless, or being in the programs that I've been in, I feel like I qualify.
So let's talk afterwards, and I'll get you a phone number and a name, okay?
Thank you.
Talk to one of the people that can help you,
Thank you.
okay? Oh, yes, go ahead.
So the new program that's, I think you said in October of this year that's going to roll out, I'm hoping that it works really well with someone who also has private insurance as well.
That's the challenge.
Yeah, because there's a lot of programs in this county, and currently, until he'll turn, soon he'll too old to be under my husband's umbrella, but currently you can't, there's certain things that he won't qualify for because he's under private insurance. And you would think, this is the part that always gets me, you would think that you want to somehow work with the private insurance because that means our Medi-Cal isn't paid for it. So it's to everybody's advantage to work together for a lot of reasons, even for the private insurance. It just never made sense to me why there's this line with it's financially to the county's best interest and potentially the private insurance too, to somehow make it work better to keep people at lower levels and stuff. So,
There are changes in the last couple of years with the Affordable Care Act, and the private insurance companies are now required to provide a mental health package that's much more extensive than it used to be. But I would tell all of you to look at ask for the information, look at what your mental health benefit is, and make sure, see what's in those benefits. I'm going to be candid, it's much more difficult if you're privately insured to get the array of services that we can provide on the public sector side. But we have additional funding through MHSA, so that funding allows us to build things out. And then there are certain services that we're required to provide as the county mental health managed care plan.
but as long as he has the private piece as well, does that mean like your program, a crisis program, that potentially could keep him from having to go to a higher level, maybe catch him earlier? Is that been bouncing out of that program too?
We're having a lot of conversations. Our programs right now are all Medi-Cal programs, but we are having conversations right now about what can we do to try to support some people that are on private insurance. It gets challenging for the private insurers and it's challenging for us because if the private insurers do not approve, then they don't cover the cost. And we don't have funding to cover the cost for privately insured clients, unless you're in a psych ER.
Yeah, I mean, New York also has Medi-Cal as well.
That's unusual. Okay, we should talk. I don't like to ask private questions, but okay. Yes?
Can you say more about the respite you were talking about?
Oh, it's an alcohol drug respite program is what we're looking at. We're actually discussing This is a long-term plan, like a 2-year plan, but we're also looking at, the county does have a sobering center, and a lot of people wind up in EPS because they're under the influence, not because they have a mental health issue, but the police pick them up and they're clearly under the influence. They go to EPS, they sort of clear up and they're released. Well, where I come from, in many counties, you have a sobering center for somebody who is under the influence of alcohol or drugs, and you place that sobering center right next door to a drug rehab unit, and you put people in there. They go voluntarily, but you set it up that way. This county lacks that, and what we're doing up in the beautiful green mountains, hilltop, I can't remember the name of. What is it? It's off Burnell. Burnell sounds right. It's a beautiful hilltop. Okay. What we're putting in place is what we're calling a respite center, because we're trying to meet, we're also looking at licensing regs, but we know that people can be under the influence, they can clear up, but they're not really ready to go into drug treatment. They need a place where they can become a little bit more stable, and that's what we call as respite care. So we're going to have options for beds where people can come in who've been cleared medically and can experience a lot of support during that moment. And then our goal is to get them right into drug rehab. So that's what it is. It isn't pure respite. It isn't hospice respite. It's really focused on substance use. Detox is a different license and requires some different things, and we're not able to put it in this particular facility. So we can provide respite, but we're looking at sobering and detox as a different unit, probably. There's a lot of licensing that goes on with mental health and substance use facilities, and we have to make sure that we are doing things appropriately in a particular facility. Yes?
My son was admitted to the hospital by police 18 months back, a year and a half back, and he was conserved. He was sent to the facility. I kept sending them letters that he's not well, he's not well. I sent letters to conservator also. He would send my letters to the facility people, and then after they did not adjust his medicines at all. After 5 months, he evolved from there, and then he was brought back by the police. They adjusted his meds, but then again, like he stayed in that facility for 1 year. Nothing much was done. His symptoms were still very bad. Then he was discharged from there. He was sent to Little House, and Little House he stayed for 4 months. They tried their best to place him in a licensed facility, but nobody wanted to take him because his symptoms were very bad. So because nobody took him, no licensed residential place took him, so then they sent him back to the hospital. Then from hospital again they adjusted his meds, again they sent him to the locked facility, a different locked facility. So my question is like, are these locked facilities answerable to anybody who's like somebody supervising what they're doing there? Because they kept saying, oh, he's fine, there's no incident, we have not observed. Like if I am visiting him once in a week, if I can observe his symptoms immediately, like they're so clear, people who are observing him for 24 hours every day, why can't they observe his symptoms? And why can't they do anything to adjust his meds? Or like, they're not showing him that he's in the locked facility, but there's no result coming up. But it feels like they're not doing anything except keeping him safe in the locked facility.
Well, first of all, if you're in a locked facility, you are assessing people. You're required to do all of that. And we have staff. I have a whole team that goes and visits to make sure that everybody's complying with what those expectations are. When I hear these stories, it's hard for me to listen because I just think there's so much room for improvement. But the stories are not unique here. I want to be clear. These are not Santa Clara County stories. These are universal stories. And so we're just gonna work as hard as we can to try to address as many needs as we can. If people are doing well in a facility, and I think many of you here, just based on the questions tonight, you know that your loved one, and most people often, in a very structured environment, people do well. They know what the expectations are, they're on medication, they have a routine. I think all of us do well. Most people do really well in that environment. And so if somebody does well in a sustained period of doing well, then for a locked facility, you're going to say this person doesn't need, pardon me, this level of care. So it's, you know, I can't respond to everybody's individual things. I don't know. I don't know all the particulars. But what you're experiencing is a common frustration. And it's also a frustration that tells me something if your son is conserved. That means that the public conservator is monitoring their care and ensuring that they get what they need. But I think in each of these situations, what I'm hearing and what many of you are expressing is environments or very specific experiences where the person you love, from your perspective, isn't getting what they need. And we're doing our best to try to fill those needs, but I want to be realistic. There's a lot of need, and we're doing everything we can to be very strategic in making sure that we've got the right services. We may not be able to address everything, but we're doing our best to make sure that the quality of care is excellent. We're hiring more clinicians that report for the county to me to go into all the facilities. We're really raising expectations about the outcomes we want to see in the clients that they're serving on our behalf. So there's, you know, we're really ratcheting up. It's not just monitoring, it's ratcheting up. If somebody's in a locked facility, we want to see them improve, and we want to see their ability to live independently improve. So that's what we're trying to do.
That's the real frustration, because he's getting everything. He's in the best care, he's conserved, he's in the locked facility, but still he's not getting better.
Yeah. And sometimes it takes a long time. It does, it takes a really long time. And then something clicks, and somebody might have the right combination of medication and supports, and it clicks, and it is miraculous. So I would also say just hold on to hope, no matter. I've seen so much of that. Okay, is my time up?
Yes.
I don't even know what time it is. I'll just sit here and talk, you know? Go have a cup of coffee. I hope this is helpful to all of you. I don't know. Bring me back. Really. Bring me back if you've got questions. I want you to walk away tonight, knowing that these issues and these heartaches and frustrations that you're raising, a family member's always on this shoulder and a consumer's always on that shoulder. I hear that. My staff hear that. I have fabulous, fabulous people working for me, with me. They're working with me. But we are doing our darndest to look at the best, most effective practices to minimize the frustration and heartache and pain you feel. So never feel shy in raising those issues. But I am hopeful that if I come back in 6 months to talk to you with these new facilities, that we might have some positive stories to report on, because that's what the goal is. So keep your chin up, be hopeful, come to NAMI, get support from the other family members who understand it. Know that you are in my heart, and you are in the middle of every discussion we have about the service delivery in this county. So you are not forgotten, and we value your input. It helps us do our work better on your behalf. Okay, so thank you.